Good morning, everyone. Welcome to this morning's session. Dr. Reba is going to take network meta-analysis. Just to give a introduction, just to give a brief background, to talk on network meta-analysis actually. Network meta-analysis is a systematic review where we have more than one option. We're comparing 2 or 3 options for a treatment. So that's one part of what is a network. It's some type of a systematic review. But in that network meta-analysis, there are many things. One is how to do the network meta-analysis. So there's a checklist called Prisma 2, how to do a systematic review. How to do a systematic review with network analysis, a Prisma network meta-analysis statement. And how to do risk of bias assessment, there is a statement in that, how to do that. That's for people who are authors who are doing the review. But for people who are reading a review, somebody else has done a network meta-analysis. Have they done it properly? So for that, there is one tool which we commonly use called AMSTAR. There's another tool called RoBIS, RoBIS, risk curve. That is to see whether somebody did a systematic review properly. One part of looking at somebody's systematic reviews, did they assess the quality of the studies properly? Somebody else has done the network meta-analysis. So first you must look good PICO question, did they search literature, PICO, then study design, searching literature, 2 people independently extracting data, entering data. That is one part, which is AMSTAR or RoBIS checklist, to see the procedure of doing a systematic. The other aspect is once they got the studies, they look at the quality of the studies. So much of today's focus of REBA will be the quality of the studies in network meta-analysis. That's called risk of bias in a network meta-analysis. Slightly specialized. So we're not looking at risk of bias of individual RCTs. For that risk of bias, that is a separate thing. That's what we do the CAST checklist or risk of bias Cochrane tool, risk of bias 2 Cochrane tool. That's for individual RCTs. Here, a network has many RCTs comparing different treatments. So the risk of bias is a little bit more complicated. It's not complicated, just a little bit more nuanced and thoughtful. Reba has taken a lot of effort. In fact, she has said much more than me. Like she was asking me questions which I couldn't answer yesterday. So I'm sure she'll do a great job. So the focus today is looking at risk of bias in somebody else's network meta-analysis. How well was it done? And assessing that. Because if you're going to change our practice based on somebody else's network meta-analysis, one way must know, did they do the process properly? That is AMSTAR or RoBIS checklist, whether the process was. Secondly, whether they looked at quality of the studies or risk of bias properly. Then you must marry those 2 together. So both of these put together, are you happy with the overall quality of the network meta-analysis? Then the question is, do you want to change your practice based on the results? If the results don't show any benefit, you won't change your practice. But if the results show this new drug is good, or second drug is good, or third drug is good, then you must make a decision, should I change my practice? So it's a little bit of a tall order, but I think Reba is up for the challenge. So all the best, Reba.
Good morning to one and all. For today's short course in epidemiology, we'll be looking at network meta-analysis, and we'll be covering introduction to it, the core concept in a network meta-analysis, as well as the risk of bias.
Around the right side is around. The left side is back. Pointer is it's just below the power. It's a bit of a.
We'll be looking at the risk of bias NMA tool, and we look at the critical appraisal of a network meta-analysis. So at the outset, I would like to give a disclaimer. It's not that any of us are experts in statistics or very well on the topic, but the goal is to give all of you an introduction to an NMA and to help you understand the core concepts. If you have this question, how beneficial is SGLT2 inhibitors in heart failure? So then you have taken this systematic review or meta-analysis. You're looking at dark cause refloxin in patients with heart failure. So if you look at the systematic review, they've taken multiple studies, all comparing one intervention, that is dark cause refloxin, to another intervention, that is placebo. So this is called a pairwise meta-analysis. So the top meta-analysis, you're looking at, you couple many studies, you're comparing two interventions, that is A and B, and you have an overall effect size. In the bottom systematic review and meta-analysis, you're taking studies which have compared two other interventions, that is B and C, and each of the studies have their own effects, and you have a combined effect. This is called a pairwise meta-analysis, which is what we all are very used to. Now, suppose you have a question for heart failure, which is the best pharmacological therapy. There are so many therapies available. They're all listed down here. But how do you know which of them is the best? You need to compare one intervention with another intervention with another intervention. It's not possible that you have studies which compare any two interventions. Like for example, you might not have studies which compare ARNI plus beta blockers directly with ARNI plus ARB plus beta blockers with blockade. But in the network meta-analysis, you're able to compare everything together and you can rank all the interventions according to the priority. So for example, you have two studies, A and B, and you have direct evidence for this study. You also have another study which is comparing intervention B and C. But you can compare actually the effect of A and C because you have a common comparator, which is B. So this comparison of A and C is called indirect evidence. So basically, network meta-analysis is whenever you compare three or more interventions. So that's called a network. So this is actually a network plot. So here you can see these blue dots. These are basically nodes. Each node actually represents one particular intervention. The size of the node depends on how many times it has been compared in that study. So for example, most of the times we compare drugs with placebo. So you can see that placebo is being used for the maximum comparison. So it's a gigantic circle as compared to the other circles. And a black line represents a direct study. That means you have done a study which compares MRA with placebo. You have a study which has compared beta blocker with placebo. And the thickness of your lines basically depends on the number of RCTs which have compared that particular intervention. So the more thinner the study, that means less number of RCTs. The more thicker, more number of RCTs have been done. So it's basically a type of quantitative analysis which can be performed as part of systematic review. It is just an extension of a pairwise meta-analysis, but here you can compare multiple interventions for one particular clinical question. And it gives you a coherent estimate of comparative effectiveness of each pair of interventions. And the best part is it allows you to rank all the interventions in a network of studies. So for example, in that previous slide I had shown, at the end of this meta-analysis, they could actually sort of rank and see which of the intervention is best. Okay, so now we'll go on to the core concepts of meta-analysis. So the first most important thing is indirect comparison. So I'll give you an example. B is basically a doctor giving dietary advice to a patient. A is a dietitian giving dietary advice to a patient. Here you have an RCT which has compared whose dietary advice is better. Does a doctor give a better dietary advice, or does a dietitian give a better dietary advice? So how can you compare the outcomes? You can probably look at the weight reduction in the patient. Here we have another study which has compared the dietary advice of a dietitian as well as the dietary advice of a nurse. But you don't have any study which has actually compared the doctor with the nurse. But in this network meta-analysis, what we can do is we can actually look at the indirect evidence with a doctor and a nurse by using the common compared to the dietitian. Okay, so we have the doctor, which is B. Then the dietitian is actually A. And we have the nurse, which is C. So you basically take the average of B and A. You see the difference between the B and A. And you look at the difference between the dietitian and the nurse. And then we can finally come to the indirect estimate between the doctor and the nurse. So you subtract the effect of B minus A, you'll get a mean difference. Then you subtract the effect of C minus A, you get another mean difference. And when you plot them together and you get this particular mean difference, that will be the effect of your doctor versus the nurse effect. So it's not just limited to 3 studies. You can add n number of studies, but the only requirement is all of these studies should have there should be a connection. They should be in a loop, which is called the network loop. Now, the next very important core principle is the principle of transitivity. So what does transitivity mean? So if you're making an indirect comparison between any two studies, all the studies which you're comparing directly should have the same baseline characteristics. If you don't have the same baseline characteristics, you cannot do an indirect estimate. So basically, the technical term for this is joint randomizability. So for every single individual study in your network meta-analysis, you should be able to pull them all together as part of one gigantic RCT, and you should be able to apply any of the interventions to anybody in the population. So it looks like one giant RCT which you have done. So how do you ensure transitivity? So first of all your studies should be similar. The baseline characteristics of the patients in each of the studies in the network should be similar. Second, the way you have designed the study should also be similar. Then third thing is the outcome measures that you have chosen for your study should also be similar. And there should be a balanced distribution of effect modifiers. What is effect modifier? It's basically any study characteristic which can actually affect your the study effect. And that should be similar in all the studies. Okay, so next is coherence. This is basically a statistical manifestation of transitivity. What does it mean? It just means that your direct evidence as well as your indirect evidence should be the same. So what is indirect effect? Suppose I have a study H and Q, but I don't see any direct connection between H and Q. No one has studied the study using H and Q. But we have a study which has compared H and P, and we have a study which has compared P and Q. So you meta-analyze this study, you meta-analyze this study, and then you come up with an indirect evidence for one indirect estimate for the probable comparison between H and Q. Suppose you have multiple other studies which have compared H and Q. You can take an average of this triangle, HAQ. You can take an average of HPQ. You can take an average of HBQ. And you can come up with an average indirect estimate. Suppose later on you have already done an RCT which compares H and Q. That means that's a direct estimate. You've also indirectly calculated the estimate between H and Q. So that's the indirect estimate. If you combine both of them together, you get this, which is called the network or the mixed treatment effect. So in coherence, what happens? The direct evidence that you have got from direct A versus B trials, plus the indirect evidence which you have got from A versus C, B versus C trials, they should be equal. So for any study meta-analysis, you have to go through the rigorous approach of going through direct evidence. You must also calculate all the indirect evidence available for that particular combination, and then you must compare it together. It's the same thing, I've just animated it. And you must also go the roundabout way, and they both should be equal. Now, why can there be inconsistency in studies? That is, in the direct study is showing one report, but your indirect loop is showing another result. Why? Probably this because the baseline characteristics between A-B study, A to B study, B to C study is different from the baseline characteristics of B to C study. Or maybe the way you have conducted this study is different from the way they have conducted the other studies. And you must also remember many of the studies are not done simultaneously. They're all done in different time durations. So all of this could actually affect your coherence. So in conclusion, if you have to say that your meta-analysis, your network meta-analysis is valid, it has to satisfy two things. For every indirect comparison, you should have transitivity. That means the baseline characteristics should be equal. And then for every loop of evidence within the network, it should be comparable or it should be coherent. Okay, so now we'll move on to the tool, which is called the risk of bias in a network meta-analysis tool, which is called the RoB NMA tool. Now, this was published very recently in March 2025. So why do you need the tool? Because when you are going to give an evidence, you're going to actually recommend one particular intervention to the population, and that should be correct. If it's a risk, if the treatment that you're going to recommend is full of bias, you'll be falsely affecting the patient outcome. So there are a lot of other tools which we use when we're actually synthesizing evidence in a network meta-analysis. That can be authors can be using some set of tools, and people like us who are actually looking at the published NMA can be looking at different set of tools. So as an author, when they're actually going through the studies, For each study, they will calculate the study bias. That's they use a Cochrane RoB tool. If there is missing evidence, they'll probably use the risk of bias missing evidence tool or risk of bias in a network meta-analysis tool. They also look at imprecision in the study. They look at indirectness in the study. They look at study heterogeneity as well as inconsistency. And they also look at their overall certainty of evidence, which is called certainty of evidence in network meta-analysis. Or they can also use a grade tool. And when they write the paper, they're supposed to follow the PRISMA NMA checklist. And as reviewers, when we're looking at the systematic review part of it, we use a RoBist tool, which we had covered last week. Or we look at the RoB NMA tool, which looks at the network, the robustness of your network meta-analysis. So today we'll be looking at this particular tool. We start off with a case scenario. So we have a 40-year-old nurse who's been suffering from migraine for 12 years. She does not take any prophylactic medications. She has only some 2 to 3 episodes per month. And for that, she takes Brufen. Her husband works as a sales representative at a pharmaceutical company, and he has come across this tablet called Lasmiditan. So he tells her, why don't you try this? So she comes and asks your opinion. Do you think it's more effective than Brufen? So what will you answer? So you said that you'll go check the evidence. Okay, so we're looking at this particular study, which is basically the comparative effects of drug interventions for the acute management of migraine episodes in adults, which was published in the DMJ in 2024. So the objective of this study was to basically compare all licensed drug interventions as oral monotherapy for the acute treatment of migraine episodes in adults. So they looked at the population, which was more than 18 years adults with an acute episode of migraine. And this migraine had to be classified according to the International Classification of Headache Disorders. The interventions they chose were all double-blind RCTs, which looked at monotherapy of drugs, which either compared one particular drug. These are the list of drugs they have taken. They've taken NSAIDs, antipyretics, triptans, ditans, GPANs, and others, and they compared it with either the placebo or another drug from this list. And they looked at two primary outcomes, which was freedom from pain at 2 hours and sustained freedom from pain at 12 hours. And the duration of the time period they were interested in was the first 24 hours. Sorry, the first 48 hours. So what were the outcomes? So proportion of participants who were pain-free at 2 hours, sustained pain freedom at 24 hours. The secondary outcome was proportion of patients who had pain relief at 2 hours post-dose. Pain relief means if they had severe headache, it became moderate headache or mild headache. Or they had a pain relapse within the first 48 hours, or they needed to use any rescue drug. Other outcomes they looked at was safety, tolerability, then for proportion of participants who experienced at least one serious adverse event. So they screened for studies. They looked at all websites of International Trial Registry. They looked at Cochrane, they looked at Medline, NDACE. They looked at the Clinical Registry of US. They looked at the EU Clinical Trials Register. They've also looked at the WHO International Clinical Trials Registry platform. They've also looked at websites of regulatory agencies and pharmaceutical companies without any language restrictions. And they've done it from 1991 to 2023. Why they chose 1991? Because the international classification for that headache came out in 1991. And they've also contacted study authors and pharmaceutical companies. So they've incorporated a large amount of unpublished data and analysis. But they could have also looked at thesis as well as personal contact with experts. They have excluded trials which use combination treatments because they wanted to study only monotherapy, and augmentation studies, that is, they use drug A plus drug B. They've also ruled out, excluded all studies which use non-pharmacological treatments. Like, for example, like acupuncture. Some people also use the TENS. And we also have some new devices, which are Nervio, all that are available. So that they've excluded. And they've also excluded drugs which are not part of the drugs which are listed in the study. So this is the PRISMA flowchart. Through the database search, they have got 7,799 records, 1,028 through International Trial Registry search, and through unpublished records, they have got 118 studies records. Then they have screened them, and potentially they have got 316 studies for eligibility after ruling excluding all duplicates. Out of it, they have excluded 132 studies because of either wrong study design, wrong population, wrong intervention, wrong comparator. And finally, for the systematic review, they have got 184 articles. For the network and meta-analysis, they have got 137 articles. If you look at the kind of articles they have chosen, almost 95% were sponsored by a pharmaceutical industry. and 89% of them were placebo controlled. Around 41% were from North America, 26% were from Europe, 9% were from Asia. The median sample size in each study was about 378 participants. The mean age was around 40, and most of the participants were all female. And 32.3% of them had a history of migraine with aura. Only 137 were included in the network meta-analysis. They have not really mentioned what happened to the remaining 47 articles. Were they ongoing studies or were they awaiting classification? So if you look at the risk of bias in a network meta-analysis tool, there are basically 3 domains. So the 17 questions which are divided into 3 domains. The first domain basically assesses the interventions and the network geometry. So the first question was all intervention and the comparator included in the network meta-analysis a reasonable alternative for the whole population? That means, could you apply all the interventions to any participant in any of the trials? So I would say the answer is no, because triptans are actually contraindicated in patients with uncontrolled hypertension, ischemic heart disease, cerebrovascular accident. So if the participants have the above condition, you can't really give triptans. So most of the triptan studies would have kept these clinical conditions as exclusion criteria. So I put that as probably false. The next question was all eligible intervention included in the study? So for this, I answered yes. All eligible interventions were included. So basically, they have looked at these regulatory bodies, and whatever they have licensed for migraine, they were included in this study. They did not include opiates because of current clinical guidance, they discourage the use for migraine because of adverse effects. So these regulatory bodies, each of them have their own licensed drug and they have their own licensed doses. So if the studies had any of these licensed doses, then they were included in the network meta-analysis. The next question is, were the interventions appropriately grouped into nodes in the network? Like I showed you in that network plot, there are nodes. So the answer was true, because the data was presented for individual drugs. So each point on the node actually correlates with a particular drug. And they have also grouped them based on drugs for the same class, the same mechanism of action, which is reasonable. So this is the network plot. So for this particular outcome, pain freedom at 2 hours, we have the placebo. You can see that each intervention is actually a particular node, and each node has actually been compared with a placebo. And you can see that they're pretty well connected. A lot of studies are actually connected to each other. This is the network plot for sustained pain freedom at 2 to 24 hours. Here we have only 15 interventions compared to the placebo. For pain relief at 2 hours, this is the network plot. For pain relapse within 2 to 48 hours, only studies with 3 interventions had actually reported this as one outcome. That's why we have the plot looks more scarce. This is the network plot for use of rescue drugs and any serious adverse events. You should note that here they have not shown any indirect evidence. That's why all the lines are opaque, because this is showing only the direct studies. They have also combined them based on the drug classes, and here is one network plot. This is for the pain relief at 2 hours. Okay, so the next question was all compared interventions connected through a suitable chain of within study comparisons? So as I showed you before in the previous picture, every single intervention was well connected. So there were no disconnected studies. So for example, if I have this is my network meta-analysis. Suppose I have another study that's for migraine, but it's not really connected to your meta-analysis. Can I include this into your meta-analysis? But you can actually use things like observational data. You can use expert opinion. You can borrow data from related conditions, and you can sort of link this disconnected trial to your network meta-analysis. But then your results will be less robust. So if they have done that, you should probably put false. The other way that I can link is, suppose F is actually, okay, let's assume F is some triptan study. E can be any of your other studies, like for example, an acupuncture. I have another study which has compared another drug B with acupuncture. I have another study which has compared F with acupuncture. I can probably use this acupuncture as a common comparator for my network meta-analysis. But you must realize that it's not good, because you're actually using an additional intervention which is not at all related to your rest of your interventions. So if they have done that, you should put them as probably true. In our study, there was no such interventions. So in the first domain, concerns regarding the domain level network characteristics, I would just say some concerns because I felt like the baseline characteristics could not be applied to every intervention. So now we move on to the effect modifiers. So as I mentioned before, effect modifier is any characteristic, either patient or study, which can affect your intervention effect. So the first question was the outcome definition and time point similar across direct comparisons in the network? I put it as insufficient data because this is one table they had put in the supplementary. Characteristics of studies including a systematic review. Nowhere is it mentioned what outcome they have studied. And it's also not mentioned what time point they actually considered. So the next thing I had a doubt was how do they actually assess pain? So pain is an outcome. There are so many ways to assess pain, either a visual analog scale or the numerical rating score. This could also probably affect your outcome. So they should at least mention studies in the characteristics, they should mention how they assess pain. So the next thing was effect modifying participant characteristics similar across direct comparisons in the network? I put probably true because the potential effect modifiers that they had identified was probably age, the sex, the headache intensity at baseline, and was the patient using any preventive migraine drugs. Though I was not able to, there was no participant level data shown for me to confirm this. They have mentioned in the study that distribution of effect modifiers on an average was similar between the compared set of trials. So we'll give them the benefit of doubt and we'll label this as probably true. So then the next question was effect modifying study characteristic similar across direct comparisons in the network? So here I put it as probably false because the good things were they used only one oral drug and they did the study only in outpatient settings. But the thing was some studies use multiple drugs in different doses. So that can actually affect your different studies. Suppose I'm comparing sumatriptan one particular dose with brufen and then using a lower dose sumatriptan with brufen, then you can see that the effect will be different. So have they done anything to address this difference in effect modifiers? Yes. So what they have done is they've done a sensitivity analysis where they have split the nodes that included high and low dose studies, and then they repeated the network meta-analysis and they found out there was no difference in the effect. So basically it didn't really matter whether they had used high dose or low dose. So overall, I would give some concerns in this domain. Now, before we move on to the third domain, which is basically statistical analysis, I just thought I'll give you an overview of all the statistics we have included in this trial. So first, for pairwise meta-analysis, they have estimated the summary odds ratio for dichotomous outcomes with 95% confidence interval. Then for the network meta-analysis, they have used a random effects model within a frequentist setting, assuming equal heterogeneity. The other method they can use is probably a Bayesian model. Here they have used a frequentist model. How do they assess statistical heterogeneity? They did tau square as well as I-square statistics. And they assess heterogeneity of treatment effects by doing subgroup network meta-analysis, and they've also done sensitivity analysis to explain any heterogeneity. What do they do with missing dichotomous outcome data? They use the intention to treat principle. So they assume dropout patients had negative outcome. Then they've also, to assume transitivity, they have compared the clinical and methodological characteristics such as age and studies reported as high risk of bias. Although they have not explicitly told us what the results were, they have done it. Then they have also assessed the reporting bias and small study effect by using contour enhanced funnel plot, which I'll come to in detail. Then to assess inconsistency, that is to see if the direct evidence matches up with the indirect evidence, they have done a global approach, and the method they have used is design by treatment test. They have used a local approach, which is back calculation and side, that is separate indirect from direct design evidence methods. And finally, the certainty of evidence, they have used the confidence in network meta-analysis framework. So because of it's an extremely lot of results are there, we just concentrate only on the primary outcome. So for pain freedom at 2 hours, they had 115 studies. Then the number of interventions were 18. The number of participants are around 76,000, and the number of events was around 21.2%. For sustained pain freedom at 24 hours, the total number of studies were only 56. The number of interventions were 15. So this is the final result of the entire network meta-analysis. So I'll explain. So each of these dark blue squares is basically your intervention. So this is for brufen, this is for lasmiditan, this is your placebo, this is sumatriptan, commonly used migraine drug. And here you can see in the bottom left, dark blue square basically corresponds to sustained pain freedom at 2 to 24 hours. The light blue squares, this outcome is pain free at 24 hours. On the right upper side of the table, the dark orange square, basically the outcome is use of rescue drugs from 2 to 24 hours. And the light orange square is pain relief at 2 hours. Suppose I want to compare the effect of L-tryptin with placebo. How will you compare? I want to look at the pain freedom at 2 hours. I want to see how effective is L-tryptin to placebo. So what should you do? First, you identify where L-tryptin is, and you come down and see where it intersects a placebo. Because I want to look at the pain free at 2 hours, I look at this particular box. How much is that? The odds ratio is 5.19. Suppose I want to study brufen with placebo, and I want to look at the sustained pain freedom at 2 to 24 hours. I'll find out brufen, and I'll look at the dark blue square, and I find that the odds ratio 7.58. If you roughly look at eyeball this table, you can see that the most effective intervention for pain freedom at 2 hours seems to be L-tryptin, and on this side it seems to be brufen, that is for sustained pain freedom at 24 hours. This is the next, which basically looks at all your adverse effects like dizziness, nausea, sedation, and fatigue. They have chosen only 4 adverse events and they have plotted the table. This is just to show that the results of each pairwise meta-analysis. I just wanted to show that they have looked at the number of studies for each comparison. For example, for acetyl salicylic acid and placebo, they had probably 3 studies. And the odds ratio was 2.31. Confidence interval was 1.66 to 3.22. They have looked at tau square, they have looked at I square, and they have given a final p-value. So finally, what they have done is they have presented the results as individual drugs, and they've also presented the individual as group drugs. So at pain freedom at 2 hours, they have done 2 kinds of analysis. They've looked at both the fixed effects. They've also looked at the random effects. So for example, if you want to see pain freedom at 2 hours with the placebo as your reference. So when you compare triptan to placebo, the odds ratio is 3.46 and the confidence interval is 3.25 to 3.69. And this is also similar when you either if you use a fixed effects or a random effect. It didn't really matter whether what they have used, but both seem to be similar. Suppose I put triptan as my baseline, I can plot the rest of the interventions with triptan, and you can see that all the summary or effects are all favoring triptan. Here they have used again fixed effects and random effects. They have plotted for individual drugs. So if you take sumatriptan as your reference drug, you can see that L-tryptin and rizatriptan seems to be doing better than sumatriptan. And sumatriptan seems to be doing better than all the rest of the drugs. And the interesting thing I found out was, if you see all the triptans seem to be on top, but suddenly your naratriptan alone is at the bottommost point. So even among the triptans, you can see that there is a variation in how the drugs act.
Your drug of choice last milligrams seems to be worse.
Yes, it's worse than sumatriptan, but it seems to be slightly better than brufen, which our patient was taking. So this is similar. Instead of using sumatriptan as your reference, they have just plotted it against the placebo. And finally, you can plot the ranks. So this is not a rankogram. They've done a very basic calculation. They just looked at the probability and seen which of the drugs seem to be doing better. So here you can see triptans, basically the p-score should be as close to 1 as possible. So here you can see that the p-score is highest for triptan. And this is the rank. Triptan is first, NSAID next, ditins is third, antipyretics fourth, and gepant fifth. So individually, L-tryptin is the best triptan. Then sumatriptan comes here, and you have your placebo in the bottom. And your naproxen and your NSAIDs all seem to be in the middle of the table. For sustained pain relief for 24 hours, they've done a similar study. I just wanted to highlight that actually NSAIDs seem to be doing better than the triptans. So for example, let's look at this table. We're comparing with placebo. Triptan, the odds ratio was, sorry, this is a repetition study. We'll go on to the next one. So for individual drugs, if you see brufen seems to be doing the best at sustained pain freedom at 24 hours. Next to brufen, you have L-tryptin, followed by rizatriptan and sumatriptan. So here they have compared it with placebo. And Brufen is in the topmost, followed by alitryptin. And the other thing I wanted to see was lasmiditan. Lasmiditan was over here. So actually, if you're looking at sustained pain relief at 2 to 24 hours, it seems to be doing better. Brufen seems to be doing better. Although in the immediate pain relief, lasmiditan seems to be doing better. So here again, you have done a ranking and you find that Brufen is the best, followed by triptans. So the next domain, so statistical synthesis. So let's look at these questions. The first question was, did the analysis respect within study randomization? So they have done within study comparisons, but they have not aggregated the participant outcomes across trials separately for each intervention group. As if the data came from one large simple trial instead of multiple trials. So that's good. So what happens is sometimes the people who conduct the network meta-analysis, what they might do is they might just pool everything, all the comparisons together, and they can just look at the overall effects. You shouldn't do that. You should actually calculate for every individual study and then pull it together. So they have respected within study comparison. Next thing is, there was no publication bias or other selective non-reporting biases are suspected. Here I wrote probably true. Though I found there were some biases, I don't think it really would have affected the study effect. So to assess publication bias, we use a funnel plot, which we learned about yesterday. So in a funnel plot is basically a scatter plot, which you're basically comparing the precision of the study to the results of the study. So the precision is actually plotted in the y-axis, and the most common measure of precision that we use is standard error. So here the standard error is 0. Down you can see that the standard error is more. And the result of the study is actually in the x-axis. Common measure is either odds ratio or relative risk. So the true effect of a study will actually be in this particular line, which is basically the overall effect of the study. And you're seeing for each individual study, where do they fall? Usually precision increases if your sample size is bigger. So larger studies are more precise. So they'll be more closer to the overall effect, and they'll also be up because they're more precise. But smaller studies will be on the bottom of the funnel plot and they'll be more scattered. So what is this particular line? This dotted line is called the 95% confidence interval. So they basically plot by calculating the average of all the pooled fixed estimate of all the studies which you have included in your meta-analysis, and they compare with the standard error and they plot this particular line. So you can see that the standard error, this 95% confidence interval actually depends on what studies that you have included in your meta-analysis. So roughly 95% of the studies should actually fall within the funnel. If it falls outside the funnel, that means there is some sort of heterogeneity. So you should also look and see whether there is any asymmetry in the way the studies are distributed. Sometimes you might have there might not be any studies on this side. That means, that there is some sort of a bias where the researchers have only published studies with this result and they have not published studies with that result. There can also be other reasons why you have asymmetry. One is if you have done a study with a very inferior methodology, that probably shows you a large effect size and that might pull the average on this side. Or it can just be artifactual, or you can just have it by chance. That is, you have such few number of studies that it doesn't really follow the triangle. So for a funnel plot, you should have at least minimum 10 studies. Otherwise, you cannot plot a funnel plot. Now you have something called a contour enhanced funnel plot. So if you look at this area of a funnel plot, because you're looking at the standard error and you're also looking at the study effect, at any single point in this graph, I can actually tell you what the p-value is, the pairwise statistical significance. So if you plot in this area, you can see that the green is not significant. It's basically 0.1 to more than 0.05. Usually our conventional significant value is P 0.05. That is shown by the yellow plot. And if it's even more significant, that is less than 0.01, it's shown by the pink plot. So all the dots which fall on the pink or the yellow, it means it's a statistically significant study. All the studies which fall in the white or the green line means it's not significant. So sometimes what happens is, you might find that there is you can see, that actually there's asymmetry. You have everything is concentrated on top. You have few studies on this side, but there is no study on this side. And if you actually see the studies which you would have expected to be on this side, they're not statistically significant. that means there is a publishing bias. Because generally, if we have a, if you've done a thesis and you find that you have an insignificant result, will you publish it? No, we'll probably compile it and keep it away. So, but on the other hand, if you look at a funnel plot and you see that the area where that emptiness is actually statistically significant, that means there's some other reason other than publishing bias why there is an asymmetry. So for in this particular study, because all the studies which I would have expected to be here are in the statistically insignificant region of the plot, I would say that there is some sort of a publishing bias. Then the next thing to note is, you can see that the significant P, that is 0.05 contour line, and the 95% confidence interval are not correlating. So they will only correlate if your null hypothesis is 1. That it's true. That means odds ratio is 1 in a fixed estimate. All the studies should be homogeneous, and each of the studies should give you an odds ratio of 1. Only then will you find these two correlating. So generally, all our studies will not have a symmetrical contour enhanced funnel plot.
Just put one more point, the previous picture, the previous to this. This is a regular systematic review. Each dot represents one study, but one study comparing 2 drugs only. This one is.
So one more thing I forgot to mention. When you actually do a funnel plot in a meta-analysis, it's very important to know that you're not each point that you're plotting is actually for that particular comparison. And in a network meta-analysis, you have multiple different comparisons. So you can't really judge the asymmetry in a network meta-analysis. So what should you do when you plot a network meta-analysis? For each study intervention, you have to subtract it from the overall meta-analysis for all the studies with that comparison. So for example, I have 5 studies comparing A and B, and my effect is 3. Then I have 1 study comparing A and B, and that particular individual effect is 2. I have to minus 3 minus 2 and then plot it for the placebo. Only then can you say the symmetry of a funnel plot. That's what they have done for this. Then the next thing is, where all predefined analysis and only those analyses reported or discrepancies were explained. Yes. So the protocol is registered in the open science framework, and whatever they wanted to study, they have in detail studied those done those analysis. The next thing is where biases in the primary studies minimal or addressed in the synthesis. So if you look at it, so for what they have done is they have given us risk of bias chart for pain freedom at 2 hours. So for each study, they have looked at the randomization process and assessed if it was low risk of bias, or whether some concerns, or was there a high risk of bias. So they looked at the randomization process, they looked at the deviations from the intended interventions, they looked at the missing outcome data, they looked at the measurement of the outcome, the selection of the reported result, and they gave us an overall risk of bias. So I just calculated for all the entire plot. So for pain freedom at 2 hours, the total number of studies were 115. For sustained pain relief at 24 hours, the total number of studies were 56. If you see, only 21% in the pain freedom at 2 hours had low risk of bias. The rest, 63 plus 80% had actually some concerns as well as high risk of bias. Similar in the sustained pain relief at 24 hours, only 29% had low risk of bias. The rest of the 70% actually had some concerns as well as high risk of bias. But what they have done is, they have done a sensitivity analysis for all the low risk of bias studies, and they showed no difference. So the next thing what they have done is, they look at the confidence, certainty of evidence. They have used the cinema framework. So for each comparison, they have looked at for example, placebo plus rimegepant. There are 5 studies, and within study bias, there were no concerns. There was low risk of reporting bias. Indirectness, no concerns. What is indirectness? Suppose in a study, for example, in psychiatric drug, I am looking at its effect on anxiety. But the study which the authors have reported is actually showing the benefit of it in depression. But I'm using that data for my study. So that's called indirectness, that you're using some different outcome and you're manipulating it towards your study. Imprecision is when the confidence interval is too wide. Heterogeneity is when your studies are heterogeneous from each other. Incoherence is when your direct evidence and your indirect evidence is not matching up. So looking at all this, they will give you one confidence rating. And you can see that of all the number of comparisons, only 1 comparison shown high confidence rating. All the rest shows low or very low. So again, so certainty of evidence in 153 comparison, only 1% has high evidence. Everything else is low, very low. So they themselves have explained. So according to our ratings in cinema, confidence in the findings was very low for most comparisons. But what they are saying is, it's probably low because of this lack of pre-specific analysis plans within the studies, or there was lack of information about randomization and allocation concealment. So they're thinking that the risk of bias is probably because the primary authors of this individual study didn't report the trials properly. Could be true. The next question was, were appropriate methods used to handle multi-arm studies? So they have done it. They have, so they've written here, we conducted a series of network meta-analysis using random effects models within a frequentist setting, assuming equal heterogeneity across all comparisons and accounting for correlations induced by multi-arm studies. But however, I didn't really understand the statistics part. They have actually given tables for it. Then the next question was, were appropriate assumptions made about homogeneity or heterogeneity of effects within comparisons? So basically within each comparison, they have used both fixed as well as random effect models, and they agree with each other. So, so they have addressed any heterogeneity within the studies. So was there any evidence of, was there no evidence of conflict between direct and indirect estimates of the same effect? So I would say probably false, because I found that there was some inconsistency between the direct estimates as well as the indirect estimates. So for that, you need to plot something called the league table. So for this particular league table, that is pain-free at 2 hours, they have done random effects using the inverse variant model. So for example, again, all your interventions are here. Here they have done grouping, antipyretic, written, repant. On top is, if you have any direct evidence, you plot it on the right upper part of the table. If you have no evidence, if you have an indirect evidence, you will plot it in the lower part of the table. So at the end of a network meta-analysis, all these boxes should have a particular value. Now let's look at NSAIDs. Is there any trial comparing antipyretics and NSAIDs? No. But we have an indirect effect which is 0.83. Is there any trial which compares placebo and antipyretics? Yes. And the direct evidence is 2. But the indirect evidence is 1.98, which is almost similar. But looking at GPAN versus triptans, the direct evidence is 0.89, but the indirect evidence is 0.5. So there is an inconsistency. And there's also inconsistency in NSAIDs versus triptans. 0.73 direct evidence, your indirect evidence is 0.66. They have also given it for every single drug. So overall, if you see, pain freedom at 2 hours, 8% of the comparisons were inconsistent. For sustained pain freedom, 5% of the comparisons were inconsistent. So how do they actually find the inconsistency? They use a global approach that is designed by treatment test. We also look at local approach, that is by using back calculation and side methods. Separate indifferent from indirect from direct design evidence methods. I just put up the table just to show that they have done this. You can just see that the treatment estimate for amitriptyl, your odds ratio is 2.6471. They looked at p-value, they calculated the tau square here. And overall, the global test for inconsistency, the p-value is significant, with the Q statistic of 42. For the local methods, they have used the side back calculation model, and there they have written percent of comparison where there is some evidence. It's around 0.1 out of 15 comparisons, there was some sort of inconsistency. Okay, so then we'll go on to the last 2 questions. Was there conflicting results between direct and indirect evidence? Was it adequately addressed? Okay, so going back to this slide. So basically, when you use a local approach, you calculate the incoherence factor for every pairwise comparison, and then you contrast with the direct estimate when available with an indirect estimate. How do you calculate the indirect estimate? You remove all the direct evidence, and from the rest of the entire network, you calculate the indirect estimate. The important thing to know is all these tests of incoherence are very low power. So even if you don't pick up any incoherence, that's probably some sort of incoherence in your study. And once you detect the incoherence, you have to look and try to explain the incoherence. Is there any error in data collection? Is there a broad eligibility criteria? Is there imbalanced distribution of the effect modifiers? So in our study, they have actually gone back and checked the entire data for potential extraction or entering errors, but they didn't identify any mistake. Then they tried to explain it with something called the placebo response. So they looked at all the placebo response for each year, and they saw if there is any break. Suddenly the placebo response has become more. And they done a sensitivity analysis, and they found there was no, the placebo effect could not actually explain the inconsistency. So I'm not sure if the conflict was actually resolved. Next thing is, so if a Bayesian analysis was performed, the choice of prior distributions was appropriate. So it was not applicable because ours was a frequentist analysis. So overall, using this for domain 3, I would say there were some concerns regarding the NMA synthesis. And putting it all together, so the bias in the results of the NMA, I have used the NMA network and I have put it as moderate risk. So some concerns are there in the risk of bias. And the last part is to actually see how the authors have concluded the network meta-analysis. Have they pushed the drug or the intervention high? Here, I would say no concerns because the authors seem to be very aware of the limitations of the study and they have not told us to follow it. They have said future network meta-analysis using individual patient data are required to improve personalized guidance for managing acute treatment of migraine episodes. So for resolution of a case, so when this patient comes to your OPD, I would probably say no. One reason is Brufen overall 48 hours seems to have a better effect than last minute. Thank you.